Acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Nishnawbe, Ishkildwen, and Nishnabeg, the Three Fires Confederacy, Ojibwe, Odawa, and Potawatomi. We acknowledge the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation. Good evening, everyone, and I will call the meeting to order. It is 5 o'clock precisely, and welcome to the February 6, 2025 Open Board of Directors meeting. I will ask if there are any declarations of conflict of interest from anybody. Okay, seeing none. I will ask for approval of the previous minutes of January 9th, 2025. They can be found in your agenda under tab A. Linda, are you approving? Thank you. And Genevieve, you're seconding. Any comments, amendments, changes? Okay, seeing none. All in favor? Thank you very much. The minutes are passed. And that leads us to the report of the acting president and CEO under tab B. Karen, over to you.
Thank you. Good evening, everyone. So my report was in the package. I'm going to just hit the highlights. So under strategic direction number 1, strengthening the processes that drive a proactive and inclusive culture of patient safety and quality of care. Just wanted to promote our We Spark Health Institute, which is our partnership between Erie Shores Healthcare, Hotel Dieu Grace Healthcare, St. Clair College, the University of Windsor, and Windsor Regional Hospital. We'll be hosting our annual research conference on March 22nd at Caesars Windsor Convention Center. So this is a premier event that serves as a really dynamic platform for health research in our community to connect, collaborate, and showcase the groundbreaking work that's occurring in Windsor and Essex County. So really proud of that work and the teams that are participating. Under strategic direction number 2, fostering an inclusive culture of accountability and transparency. We hosted 2 education sessions in January with Elder Mike Hopkins on smudge ceremony at both of our campuses, Met and Olette. And these sessions covered what a smudge ceremony is, the importance of smudge for our Indigenous patients and families, as well as a demonstration. It was very well attended and enjoyed by all those that participated. Under strategic direction number 3, maintaining a responsive and sustainable corporate financial strategy. Our very long-lived donors, the Gunther and Judy Funkenhauser, presented our Regional Hospital Foundation with a check for $23,000, and this was raised from the annual Trevor Lewis Funkenhauser A Day for a Life golf tournament that honors Gunther and Judy's son Trevor, who passed away tragically in 2006 following a courageous battle against endocarditis. Following his death, Trevor's organs were donated through the Trillium Gift of Life program, saving the lives of 3 people. So the Funkenhauser family has held their golf tournament since 2007, and they continue to raise money each year for hospital improvements and promoting awareness for organ and tissue donation. The funds raised from last year's tournament will go towards much needed equipment for our intensive care unit, as well as waiting room upgrades. So we do want to thank the Funkenhauser family for their ongoing support. Under strategic direction number 4, enhancing an equitable workplace culture that establishes Windsor Regional as an employer of choice. We'll be hosting our 2024 Dedicated Years of Service Awards this coming month on February 19th and 20th. So we'll have over 519 staff this month that are in that Dedicated Years of Service program. So really proud of the team and all they've given to our community over many years of service. This year, this past year in December, we also had over 770 of our staff participate in the 2024 Quality of Work Life Survey, which provided the opportunity for them to give the organization valuable input and views on the overall work environment. And we held our virtual town hall with our staff and professional staff on Thursday, January 30th, to go over the highlights of the survey results and the improvement plans. So that served as an opportunity for staff to speak directly with the executive team regarding their questions and concerns, And over the next 3 months, we'll be actively working with our teams, including our frontline, to roll out improvements based on the feedback and suggestions received from our staff. Uh, Under strategic direction number 5, enhancing collaboration and strengthening partnerships to build a better healthcare network. We are continuing to collaborate with the Windsor Police Service and the Nurse Police Team program. From January to December of last year, the team has responded to over 2,000 calls, actually 2,296 calls for service. 443 independent assessments were provided. We provided 494 substance and mental health provider referrals, 488 social service provider referrals, over 300 naloxone kits, 195 fentanyl test strips. We treated 43 overdoses and 175 substance related wounds and diverted close to 730 persons from our emergency departments. We also collaborate with Windsor Police Service, Family Service, Windsor Essex, and Hiatus House on the Intimate Partner Violence Response Team program. And between October 2024, when it was launched, in January 2025, the team has provided over 27 days of service and responded to 19 calls for support. Under strategic direction number 6, designing and delivering a new state-of-the-art acute care facility with the community for our region. As we reported last month, efforts are underway to advance the first phase of the project, which includes the construction of a parking garage, education, learning, and administration building, as well as the site works necessary to support the infrastructure for future phases. These developments will ensure adequate on-site parking and workspace to support construction activities for the main facility. And there's a competitive process in place to select a construction team. So we are expecting that to conclude this month and looking for lots of exciting activity to start after that. I do want to highlight we have had and have been experiencing very high emergency department wait times. So we will ensure to share information again about the options that are available in the community when it is not necessarily an emergency. Obviously, if it's something that's urgent or emergent, we do want you to come to the emerge. But there are some virtual clinic options, Health 811, Healthcare Connect, walk-in clinics, and MD Connect available in the community that provide other options with shorter wait times than the emergency department when appropriate. So we'll make sure to share that on our social media. Again, we've been blasting that out at regular intervals, and you can also find that on our intranet site. So thank you. That's the end of my report, and I'm happy to take any questions.
Thank you so much, Karen. Any questions or comments for Karen? Okay, seeing none. Karen, I did just want to take the opportunity to highlight the retreat on January 28th. First, I'd like to thank the board members that did attend. And Karen, thank you to you and the entire administrative team for their very, very detailed and obviously well thought out presentations. It was really nice to see how the operations and their strategies aligned with the strategic directions that were endorsed by the board. So again, just kudos to everyone involved. And again, thanks to the board members that participated. Much appreciated.
Yeah, thank you. The teams did an amazing job, and we're really looking forward to rolling out those operating plans in the coming months and seeing the improvements we can make. So thank you for that.
Okay, that leads us to item number 5 on the agenda and the Schulich report. And I believe Dr. Jacobs could not be with us this evening. That was for information purposes. And that leads us to item number 6, financial presentation under tab C. Anthony, I'll turn it over to you.
I'll figure out this unmute button before I leave the board, I swear. But it doesn't bode well. So good evening, everybody. Thanks for being here. So we are going to present our December 31st, 2024 financial results. Again, this is 3/4 of the way through the year. So this is not end of year. End of year is March 31st for those following along at home. Next slide, please. Very briefly, if you take a look, the net deficit after building amortization is $18.6 million, which is actually $2.1 million better than budget. So we're very excited by that. The hospital margin is a negative 12,583,000, which also is better than planned by 1.7 million dollars. So overall, based on what we were forecasting at the beginning of the year till now, we are doing exceptionally well. The team is looking for savings wherever they can. So kudos to the team. So we can move to the next slide. So we've made a couple of changes here that we were still workshopping, I guess the best way to put it. So period to period in benefits, if you look at prior period yet net year to date versus net this period, you see a large swing. That's essentially a timing issue to budget. That should kind of moderate as we end the year, the next 3 months. Moving down, we have medical staff fees. So the big swing is we have a considerable amount of money that was paid to a specific set of physicians during Code Gray, where pay them. We are working out plans to get those funds back. So that is the big discrepancy there. We thought we'd have it completely cleaned up by year end. Unfortunately, that was not the case. So we'll be working on that as we close out the year. Med surge supplies, unfortunately, we are on track. We are still tracking with a big deficit there. But month to month, there were no big hiccups in comparison to prior months. Moving on to drugs, and again, if anybody has more specific questions, happy to answer them. Again, drugs, following the same pattern in terms of deficit growth by month, is status quo. Again, we're looking at things that we can do to reduce waste in our drug program. Things go bad fairly quickly as it relates to drugs. So sometimes looking at reporting is one of the things that we're looking at. There's a lot that the team is looking at to reduce that deficit. And then the ever-present other supplies. Again, building maintenance and equipment is a lot of that. We are on trend, is the best way to put it, between month to month growth. Again, we operate in a old building is one part of it, but number two is we are still recovering from Code Gray. So every once in a while, a invoice pops up that hadn't been paid during that time. So those were unaccounted for in the prior year and have now reared their ugly heads is the best way to put it this year. So there were a couple of big, fairly large invoices that came up this year that we weren't expecting. So if we can move to the next slide. Again, so we have our sick hours as a percentage of work. Again, we are above where we want to be. That is, again, these are numbers for both hours worked and worked overtime hours. You can see the correlation essentially. So the more sick time we have, the more overtime hours we have. It's pretty clear. So we are doing, HR is working to try and come up with a plan to make these numbers a little bit better or try and reduce the amount of sick time. And conversely, the overtime hours worked. So we're in the process of looking at things that we can do to reduce that. So for next time, what we're going to do is actually show a 2-year trend. That way you can kind of see a bigger picture. And I think that is it. Did anybody have any questions?
Any questions for Anthony?
Getting off easy.
I don't see any, Anthony. Do you want to move that report before?
I will
Okay.
move. Yep, perfect. I will move the report.
Okay, and Dr. Freeman has seconded that report. All in favor, seeing no additional questions, all in favor? That motion passes. Thank you, Anthony.
And then I would like to make a motion to accept the consent agenda.
Okay. That can be found under tab D, showing the information as of January 27th, 2025, and again, the operating results. I think, Paul, do you have a question, Paul, or are you seconding? Seconding? Okay. Any questions for Anthony under that agenda item? Seeing none, all in favor? That also passes, Anthony. Thank you.
Thanks, Madam Chair.
And we do have a special presentation this evening that was suggested by the Quality of Care Committee, and it's how healthcare funding works in Ontario. I've been on this board for over a decade, and the fact that it simplifies things for me is a good thing, because I'm still not sure how healthcare works in Ontario right now anyways. But Heidi presented to the Quality of Care Committee, and it was suggested from that committee that that presentation be provided to the Board of Governors, again, as an overview on healthcare funding in Ontario. And it was really praised for its clarity and the summary. So with that, I believe that we have it on video and we are going to watch it. Thank you, Matt.
Hello, my name is Heidi Zimmer and I'm the Director of Financial Services at Windsor Regional Hospital. The following presentation is a general overview of how hospitals in Ontario are funded. The funding model for Ontario hospitals is based on health system funding reform, which was implemented in 2012. At that time, the Ministry of Health transitioned to a health-based allocation model, or HBAM, to partially fund hospitals more directly in alignment with the type and quantity of services provided. This is the patient-based funding component of HSFR. The health-based allocation model incorporates into the funding allocation population demographics and clinical needs of communities served by a hospital. These variables include age, gender, and growth projections, as well as socioeconomic status and geography. Funding is comprised of three main streams, which are global funding for activities that cannot be modeled or are otherwise unique, the health-based allocation model funding, or HBAM, which takes into consideration population and clinical needs of the community, and patient-based funding, which fluctuates based on the type and quantity of services provided. Quality-based procedures, or QBPs, fall under this type of funding as they are funded on a price times volume basis. It should be noted that HBAM uses data that trails funding by 2 years, meaning that service changes that occurred in fiscal 23-24 would affect a hospital's funding for fiscal 25-26. In fiscal 19-20, the funding model was updated to allocate growth investments through a growth and efficiency model, or GEM. This approach incorporates the principle of activity-based funding, recognizing patient population and service growth, using HBAM's pricing model to encourage efficiency. GEM is in reality an allocation model rather than a funding model because it is applied to incremental investment only and does not redistribute existing base funding among hospitals. The GEM approach builds on the components of HBAM such as population growth and service trends, but does not depend on the more complex components of the model. This graphic illustrates the breakdown of Windsor Regional Hospital's base funding allocation under health system funding reform. Prior to HSFR, hospitals received a lump sum for funding that was not tied to demographics or volumes. Post-HSFR, looking at base funding for fiscal 24-25, we can see that 51% of our funding is global, 28% is based on the HBAM GEM modeling, and 21% is for quality-based procedures, QBPs. QBP funding reimburses hospitals for specific procedures on a set price times volume basis. The base price is then adjusted for each hospital's patient complexity weighting called the Case Mix Index. Examples of elective QBPs are surgeries such as hip and knee replacements, cataracts, and tonsillectomy. Non-elective QBPs include pneumonia, stroke, and hip fractures. Cancer services that are funded via QBPs are chemotherapy, radiation therapy, cancer surgeries, and GI endoscopy procedures. The Chronic Kidney Disease Program, also known as the Renal Program, is also funded as a QBP. This graphic illustrates how Windsor Regional Hospital's GEM allocation for fiscal 24-25 was determined. Through the HBAM-based formula, the hospital's growth expenses were calculated to be $15.3 million. This amount is divided by total provincial GEM growth expenses, meaning the growth expenses for all the hospitals included in the model to determine our share of the GEM allocation. In this case, approximately 2.1%. That percentage is applied to the total provincial funding envelope of $543 million to arrive at our share of the GEM funding, roughly $11.5 million. The hospital receives funding in addition to base as one-time funding. This funding is designated by the funder, usually Ontario Health, for a specific purpose or for a specifically designated time period. Examples of one-time funding are the Emergency Department's Pay for Results program, critical care training funds, and health and human resources initiatives such as the Enhanced Extern program. One-time drug recovery funding is applicable to the chemotherapy and renal programs, whereby the ministry reimburses hospitals for expenditures on certain high-cost drugs. The majority of physicians working in the hospital are not employees of the hospital. Many physicians in Ontario have established professional medical corporations. There are a few salaried positions in the hospital, and physicians are paid mainly by billing OHIP directly on a fee-for-service basis. With a few exceptions, there is no direct hospital involvement between specialists and OHIP. Where the hospital does play a role in physician compensation is in alternative funding agreements. In these cases, the hospital is contracted with a group of physicians to provide services in areas such as the emergency departments and the NICU. Funds are flowed to the hospital by the Ministry of Health and then distributed to individual physicians in that group based on the agreement. Hospital on-call coverage is another funding stream whereby through an agreement with the hospital, physicians provide on-call coverage by specialty. Examples of such specialties are internal medicine, neurology, and anesthesia. The funding is flowed to the hospital, then distributed directly to physicians within the guidelines of the funding agreement. The hospital bills OHIP for diagnostic services such as X-ray, CAT scan, and MRIs. Payments to Windsor Regional by OHIP are comprised of two components, a technical fee, which is for the use of our facilities, and a professional fee, which is flowed to the radiologist or specialist who read or interpreted the diagnostic test. Capital equipment purchases are funded through operations, and there is no funding stream from the Ministry for capital equipment. In order to fund equipment purchases, the hospital needs to generate surplus cash for investment. Major construction projects such as the Cardiac Catheterization Lab and the Linear Accelerator have separate approval and funding mechanisms. These projects also require a local share contribution of at least 10%. Hospitals in Ontario report to the Ministry of Health under their Management Information Systems Guidelines requirements. These guidelines specify a capitalization threshold of $5,000 for new equipment, information technology systems, or anything that substantially improves the value of an asset. The Ministry of Health generally does not fund building or equipment capital purchases. However, specific funding has been awarded for certain projects such as our Cardiac Catheterization Lab and Linear Accelerator in the cancer program. Through the Health Infrastructure Renewal Fund, hospitals receive funding to cover capital improvements for aging infrastructure. HERF funding for Windsor Regional Hospital in fiscal 24-25 is just over $2 million. As you can see, hospital funding is complex. I hope this presentation has provided some clarity. Thank you.
Thank you so much. I don't think Heidi's with us this evening, but Melissa or Ian, is there anything you wanted to add?
Oh, just that it was really well received by quality of care, which is really a good indicator that we're kind of trying to communicate, you know, in very technical financial things to not necessarily all financial related people. So that's kind of the goal of us trying to just make sure everybody both within our building and outside of the building really have a better understanding of the funding model in Ontario.
Well, thank you, Melissa. And please pass on our thanks to Heidi as well. Sorry, Ian, go ahead.
I'd like to add to Melissa. It's interesting. It was around last October, Karen and I attended a quality of care committee meeting in late September, and we realized with the new members on and the questions they were asking, including some of the existing members of the quality of care committee, how complex the funding model is. So we put it in the capable hands of Melissa and Heidi to come back with something that was relatively simple. And one of the quality of care committee members said, I'm in social work and I actually understand this. So that I think was a great compliment to Melissa and her team, and our compliments. And please, again, Melissa, thank Heidi for what she did for us. I think this is outstanding work and we will use it for orientation going forward.
Absolutely, Ian.
I
So
will do
thank
that.
you again. Okay, seeing no other questions or comments. Again, thank you for that. That leads us to item number 8, correspondence and printed material, which can be found under tab E, and that's just for information purposes. Are there any board members' questions, comments, or notices of motion? I do not see any. So that leads us to the last item on the agenda. The date of the next regular board meeting is on Thursday, March 6th on Zoom. So thank you everyone for joining us this evening, and we will see you again next month. Thank you. And we'll see you on the next link for in camera. Thank you, everyone.
Good night, everybody.